point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery. and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. Easy flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And hello, everyone. Welcome to PerfWeb 38, our second journal club, and we are Tammy Sparacino's Journey Club, I should say. Very quickly, I'm going to go through the housekeeping notes and get them out of the way so we can move forward. Our sponsors, click on them. We appreciate them. We need them, and it really helps me tremendously to help keep this program going. If you are to, do we put the sponsors up? I haven't seen them. There they are. And if you click on those links, let them know you saw us here, that you watch our program. Look, at the end of the day, we need their support, and I need your help in letting them know that we are reaching a very large audience, and it's very helpful for us if you do that. So thank you. I appreciate it. The social media. Of course, we're on all of them. We need you to like, follow, share, subscribe, click the notification buttons on the Facebook, the Twitter, the LinkedIn, and the YouTube channel, okay? So we've got all that stuff. We're really building, continuing to build on subscribers. We are now, I will say this, the #1 subscribed to perfusion YouTube channel. And so we are really pleased to be #1, but we want to be #1 by a long shot, not by a nose. So I need more of you to subscribe. Share it with your friends, neighbors, take it, to the library, leave it up, whatever you want to do, don't care. But subscribers, we need you. Actually, obviously, we really do care. We want people like you who are professionals out there in the trenches every day doing this job. Because I'm going to tell you, I don't know if you notice or not, but I'm tired. This has been a really rough couple of, probably month or so, I guess, here in Houston. And if you're watching the news, Houston sort of got walloped. But we're getting through it, and I've said it many, many times. It's like anything else. You take care of whoever is in front of you at the moment, do the best you can, and this too shall end. But for those other places out there that have either already suffered or are suffering along with us, or will be suffering potentially in the future, just fight the good fight. That's all I can say. Check out our websites. If you'd like to join our faculty, there's our website address was perfweb.us, I think, and then that's our email, contact@perfusioneducation.com. Send us an email if you'd like to join our faculty. We'd love to have you. If you would like to suggest a topic, suggest, maybe some addition to the show that you think would make it better to the program, I would love to hear from you. So please do that. Our call-in number, you'll see there. The phone lines are open. I'm going to open them up right away. So we're just going to leave the phone lines open tonight for the entirety of the program. Call in whatever you want if you would like to discuss something that is, germane to either the program, the topic at hand, or whatever the case may be. Okay, so I think I got through all the housekeeping notes. Where do I go to from here? I think, do we just put up there's John Ingram. There you go. So this is a special edition. I didn't say that, and forgive me for that, but this is a special edition of Tammy Sparacino's Journal Club. As you can tell, Tammy's not here, right? John Ingram, however, is, thank God. So this might actually be a good show. But Tammy had a matter that she needed to attend to, and she asked me, and I was quite humbled by it, if I would fill in for her. So I am Tammy's fill-in. I was going to get a wig and wear it and stuff like that, but I decided not to, because I know Patrick did that once. He hosted the show, and he had a bald wig that he put on. It was kind of funny and cute, but I decided not to do it for whatever reason. All right, so let's just jump right in. If you could put my slides up, I'd appreciate that. You're not supposed to do that. I did that, and you're not supposed to do it, touch your face. So there is our little primer that we have. Of course, the topic today is going to be autologous-rich plasma separation technology used in the same patient receiving 2 complicated aortic surgeries within a short time period. And this is a published case report. And then we're going to follow that up with our inaugural M&M conference, which is essentially sort of themed learning from others' mistakes. And this is a case that I go out and look for especially in the legal system or in the news media that is pertaining to perfusion and has a level of sensationalism to it, something that's very remarkable happened. And what it was that happened that made it, because we don't want to be in the news, right? We don't want to be in the newspaper, especially when it involves a lawsuit. So it's going to be very interesting, I think, doing this M&M. I'm excited about it. And the first case we're doing, I think, is going to be very, very interesting. Okay, so next slide, please. Yeah, just click it. Okay. So here is the article. The article was written in the Journal of Medicine, and the title is Autologous Platelet-Rich Plasma Separation Technology Used in the Same Patient Receiving 2 Complicated Aortic Surgeries Within a Short Period of Time. And the author is Yi Chang, and I can't say that first name, but Zhang, kind of rhymes there, and another physician with the last name Ayang Tian. They're from the Department of Anesthesiology and the Department of Gerontology and Geriatrics, the first affiliated hospital of China Medical University in Shenyang, China. So that's the article and the title slide, and who wrote it. So I'm trying to pull those slides up here myself, and I'm really having a hard time finding them. So, please forgive me. Give me just 1 second, if you would, guys. I'm looking. There it is. Okay, got it. Perfect. All right, that really helps me. All right. So here's the abstract. The rationale is that autologous platelet-rich plasma separation technology has been widely used in various clinical therapies and has achieved good results, especially in aortic surgery. Now, I want to sort of tell y'all that when I first saw this article, and Tammy and I were talking about it, I thought they were talking about PRP. You draw out 60 cc's of blood and you process it in a little centrifuge, and then you give them the 10 cc syringes full of the PRP, the PPP, and the calcium thrombin mixture. But patient concerns, 50-year-old male, that's not what I'm talking about though. A 50-year-old man who was diagnosed with aortic dissection, Stanford B type, and a thoracoabdominal aortic aneurysm and grade 2 hypertension underwent 2 complicated aortic surgeries within 4 months. Well, I mean, we know that those operations can be, I'm sure it was an elephant trunk, is going to result in a lot of bleeding. They generally do. The diagnosis was aortic dissection type B. The interventions were PRP separation used as a blood protection measure, was employed in both of the surgeries. And then the outcomes, the patient's coagulation function recovered well after the surgeries, and the amount, they believe, of allogeneic blood products used in the perioperative period was small in comparison to what they expected. And the lessons that they learned are that PRP separation technology combined with blood salvage, meaning autotransfusion during the procedure, and warming of blood and fluid transfusion in the aortic surgery has been proven to be feasible and beneficial. So let me go straight to why was this paper published, the significance of the study, if you will. Well, the paper, the way I see it, was written for 2 significant reasons. And this is my opinion, okay? This is how I viewed it. One is to discuss the benefits of autologous blood collection, which we also used to refer to as ANH, and also to discuss platelet separation using an ATS technology, autotransfusion technology, to separate and reinfuse what they're calling PRP. I would call it segregated plasma, on a patient undergoing major aortic surgery and then a second. It is a strong anecdotal experience. So that, and I think that might have been a little generous when I wrote that, but because I don't want to beat this paper up too bad. That's really not my intention here. It's more to just stimulate conversation. But at first blush, John, what say you? What do you think?
Yeah, I just wonder if in translation, this was probably published in Chinese originally, and then maybe in the translation, their best translation was to call it PRP. And I think you are right to point out to our viewers that this paper is really not talking about platelet-rich plasma in any sense that I've ever seen, and I think probably most of our audience, because it implies that they somehow concentrated and concentrated the platelets into a plasma solution. And really all they did was separate it from the red blood cells. And really what it is, it's platelets present in the plasma is really what it is in a normal concentration.
Yes, but at the same time, and let's explore the article, I think, when we get to the methods and procedures. I think that's going to be important. But let's throw the slides back up, please. So what was, the who, what, why, and where, right? Problems to be solved. So post-operative bleeding secondary to platelet loss and dysfunction following major aortic surgery with the use of CPB. So that's what they're trying to address, the way I see this, because I do think that when you take patients and you put them on pump, and then you do deep hypothermia, circulatory arrest, and you have a protracted pump time with a lot of suction, you're probably going to have a lot of platelet loss and dysfunction. There's something that I think I'm not 100% sure they did it, but I will talk about a little bit of that theory that I have about how, if you were going to do this, to make it most effective. But those platelets in that plasma are going to have a higher degree of functionality, having not gone through a major surgery like that with the pump, temperature, so forth and so on. How do you feel about that?
Yeah, absolutely. I mean, there's a fair amount of evidence that if you can keep platelets and even the coagulation factors off of the artificial surface for the amount of time that they're going to be exposed to, that the evidence shows that there is a decrease in bleeding. There's actually mixed evidence as to whether or not you decrease your amount of transfusions that the patients receive. This paper is going to claim that transfusions were far less in this particular case, but the overall body of publications that are out there are going to indicate that acute normal bulimic hemodilution is sort of what they're talking about here, does decrease bleeding, but actually has minimal impact on overall blood transfusion usage for the most studies that are out there.
Yeah, I think you're right, and I'm not going to say I'm 100% certain of this, but I'm 90+% certain that it is a 2B recommendation, I believe, by the STS, where it may do some good. It certainly isn't going to do any harm, but there's really not enough supportive evidence that A&H works. And I think one of the big problems, John, and I guess I'll sort of address it. I'll tease this concept, but because I want to talk about it a little more later on. But one of the big problems with A&H is that you are creating an environment by which the patient that would have had a much higher oxygen delivery index during the procedure now has been cheated out of that. So, there's a, no pun intended, since this is a paper from China, but there is a yin and a yang, right? You're never going to get one thing without sacrificing something else somewhere. I mean, that's just the way this business works, and that's how medicine works, I think, in general. What do you think?
Yeah, I think it would have been nice if the paper would have pointed out, and not to criticize the paper, I just noticed a void in the commentary about whether or not they gave the red cells back right away or during the pump run, or whether they waited after. It was not really clear. And I also wondered, why did they separate the two? Because it makes it useful in that case to separate it if you can, take advantage of the fact that you can give the red cells back. And as delivery of oxygen and goal-directed perfusion is emerging, this particular technique may kind of take a kick to the gut, so to speak, if you're decreasing the patient's oxygen carrying capacity significantly, and then all in the name of trying to hold off a unit of blood that you can give back later. So it's going to be interesting to see how those two come together. And we can talk a little bit later about how many people do you think are actually actively employing this acute, normal bulimic hemodilution out there. It'd be interesting to hear from some people, but I've read some things that it's about 15% of the cases consider using this.
Yeah, I think, we're gonna, poor Tammy, I'm gonna completely mess up what her flow is supposed to be. She tried to explain it to me, but I can't help it. This is the whole point of this discussion. I think A&H, I kind of view it similarly to RAP, in the sense that I think that the risk outweighs the benefit. Now, if you have a pump, and the argument is well, you don't give the patient a 1,500 cc volume of hemodilution when you go on pump. Well, I mean, that's true. That's if you do RAP, right? But again, how do you have enough volume unless the patient is hypervolemic already to be able to get away with that? Like the old days when we did mitral valves, we had, I mean, it was like the biggest fear ever was to go on pump and have the blood pouring out of the top of the reservoir. These people were, I've seen hearts that were as big as basketballs in the old days, these old mitrals. And we don't see that anymore. I mean, it just doesn't happen. But if the patient is normal, is euvolemic or even typically dry, then you're going to take the volume out and you're not going to be able to have a high enough flow, and then you're either going to have to really dilute them even more. For what? What's the point? And I just have never understood it. And I think the same thing applies, in my view, to A&H. I think it is a very misguided approach that some people, and I don't mean perfusionists, I actually think it's more from a different end of the table, from our side of it, who view it as the way to do it. And again, at what cost? If you take 500 cc's, let's just hypothetically say, of their blood, I mean, probably not that bad. You could get away with it probably most of the time. You are going to have to replace it. But, you know, during the course of the case, if you have a hemoglobin of 7 or 6 or, you know, 5.5, are you going to say, oh, I'm not going to treat that because I'm going to come off pump and I'm going to be able to give that unit of blood? Well, that unit of whole blood, pending what their starting hematocrit was, even if it was 40, is not going to do much for you. It's just not much. It's not much volume. What is that? 260 cc's, 270 cc's maybe of that blood, or maybe a little more than that, I guess. If you took 500, what would that be? 40% of that, 60% of that would be how much?
It's not very
300.
much.
So 300 cc's,
some of the
you're going to have
studies have
300
shown
cc's
that unless
of plasma.
you do an 800 to 1,000 cc volume, then you can't really impact it very much.
Yeah. How many platelets are in 300 cc's of plasma? 300 cc's. Really?
Well, if your crit's 40, then it's 60% as plasma, and then
right,
you
but
get
how
a
much?
fraction
Right,
of
that's
that
300 cc's. You take 500 cc's, 300 cc's of it is plasma. How many platelets are in 300 cc's of plasma that are going to save you when this is all over with?
I mean, it's you know, it's, what is it, 1/9 of your blood volume total that you've taken out or something like that.
Yeah.
Maybe less than that, and then, you know, so that's about
I think
how
my
many
point is,
percentage of platelets you've taken out.
point is that I think it's pointless and it's silliness. And if you take a liter, sure, you could get away with that. But if you take a liter out of somebody, I don't care if their crit's 40 or not, unless they're, you know, big, giant person with a tremendous amount of volume. But even then, you're going to have a deficit in your perfusion because it's going to be very difficult to flow enough without the oxygen carrying capacity, because you have the limitation of the cannulas. You have the limitation of, you know, all kinds of things. So it just doesn't make it. The point is, I think it doesn't make sense and it's pointless. Okay, we'll go to the slides back. So how? This paper is predicated on a common understanding, which we've already just discussed, that coagulation derangements, excessive bleeding, and significant transfusions of blood and blood coagulation factors are necessary after major aortic surgery involving prolonged CPB and deep, profound hypothermia. Now, I have done aortic dissection cases before where I have actually had the patients like chip dry when the operation was over with. I couldn't believe it. I've had several of those actually. But then you also get the ones that bleed like, you know, bleed like hell. And there's almost nothing you can do at that point in time. So, you know, I don't know if this was beneficial or not. So throw the slides back up. I'll throw this next one up. And we'll go ahead and read the case presentation. Patient is 50-year-old man with a body BMI of 25.7. So, you know, not bad for I guess that's in China, because here in the United States, I mean, you couldn't find one under 30. And a 1-year history of hypertension, who was preoperatively diagnosed with aortic dissection, Stanford type B, a thoracoabdominal aortic aneurysm, and grade 2 hypertension. The treatment plan consisted of staged reconstruction surgery, so an elephant trunk, aortic arch, and full thoracic and abdominal aorta. The patient was provided informed consent for the publication of their case. And then the procedures and methods, materials and methods, autologous blood was collected through the right IJ and separated into 878 mLs of PRP. So that's a fairly large amount of plasma, and 497 mLs of RBCs using an autotransfusion blood separation device. In this case, they used the what's Sorin or LivaNova Extra, but you can use the, I know Haemonetics, you're able to do it. I'm not sure if you could do it with the Fresenius machine, but I know you can do it with most cell savers you can do this with. The PRP was stored under continuous shaking at room temperature. I think they really meant movement as opposed to shaking, and kept at 22 to 24 degrees centigrade. The autotransfusion blood separator device was used to achieve and concentrate the whole blood lost during the time from cutting skin to closing the chest. So that's fairly, I think, standard practice here in the United States, certainly. As the first stage of the surgery, the total aortic arch was replaced and a stent was placed in the descending thoracic aorta. With routine monitoring, the patient was induced with intravenous anesthesia and a maintenance of intravenous and inhalation or volatile anesthetics, gases. Intermittent blood sampling was conducted for blood gas and electrolyte analysis. TEG was used, interestingly enough, to monitor the patient's coagulation function, as fairly advanced. And during surgery, external warming and warming of transfused blood were employed to prevent hypothermia. Now, I'm assuming that they mean that in the context of during when they were warm already, not that they were using hypothermia and then warming the blood to give it to the patient. And then this is their little circuit that they show, and then you can see the cell saver machine, the patient taking the blood and separating it into red blood cells, and then ultimately PRP. I'm not sure what the line is going back to the patient, since they're not going to give it back to the patient that way, but maybe that was for later. I'm not really sure. Okay, because you would think they would just hook it up to anesthesia. And so we'll go into after heparin neutralization with protamine. Post-operatively, obviously, PRP and autologous blood cells were transfused back to the patient. So they do actually state it, John. It's right here. That they kept both. They didn't give the red cells back to the patient, although I think that would have been a smart thing to do. A total of 251 mLs of concentrated RBCs were collected during surgery, so not very much. Another 2 units, basically one bowl, another 2 units of allogeneic RBCs, 2 units of platelets, and 20 units of cryoprecipitate were administered. So they did give blood transfusions, but that's not a massive amount. The total urine was 750. That's reasonable. The surgery lasted for 4.5 hours, and the patient was admitted to the cardiac surgery intensive care after endotracheal intubation. After the first surgery, the patient received no allogeneic blood products. Now, that's very interesting. And just let me make this final point. The platelet count before, immediately after, and 24 hours after surgery were 218, 173, and 198, respectively. And the MA value of the TEG before, immediately after, and 24 hours after surgery were 71.8, 69.8, and 70.1, respectively. So we can take the slides down now, but that's, they gave 2 units of platelets, and they gave 2 PRBCs, and they gave 20 of cryo, but post-operatively, that's not bad. Really, that's not a lot of blood, but it's not none, right?
Well, I'm confused. You just told me how much blood they gave, and then it said they didn't give the patient any blood.
Post-operatively. They did intraoperatively. They're in the ICU. The patient.
In the ICU? Oh, well.
Yeah, in the ICU, the patient did not receive any more transfusions.
Okay. So what they're trying to say is they had good control in the post-operative phase of the bleeding. They had good control of it from what they did. So, I guess they have a history, and most people do. You give a lot more blood than that on these type of cases. And they had this particular gentleman where they did this one technique, which is kind of a little hard to imagine. If you have a blood conservation program, it has to be wide, multidisciplinary, from pre-op all the way from the cath lab, being conservative with blood loss, to eliminating your antiplatelet drugs, eliminating your anticoagulation drugs the patient's on, maybe giving even antifibrinolytics. The ANH that we're talking about is one spoke out of many spokes in the wheel of a blood conservation program.
Agreed.
It's nice if this really happened in the way that they're saying. They tried this sort of one technique, or maybe they added this to what they were doing, and they saw remarkable, positive results in this patient. But I don't want people who are viewing to think, well, let me just add this to our repertoire. We're going to have a tremendous decrease in our blood usage and blood transfusions at our hospital, because the blood conservation program is multifaceted, and you can have a good operative blood conservation program and have it fall completely apart in the unit, or even up on the floor if they start transfusing the patient up there. So it really has to be multifaceted, multidisciplinary for a good blood conservation program. Don't get the impression this one technique is going to come in and save the day.
Yeah, and you bring up that's such a, I think, valuable piece of information. Let me throw this out at you, and I know we are going to get through this entire paper, believe me, but Timothy Gannon, hey Timothy, how are you? Asks, what are your thoughts on the benefits of giving the red cells back while on pump? Well, I think we actually probably answered it, but I want to answer it again, and that is that I believe that we accept too low of an O2 delivery, or DO2, DO2I, delivery of oxygen index on pump. And I think that compared to our native circulation when we're on pump, now recognizing we're under anesthesia, we're paralyzed, I get all of that. But we're also removing the sort of native circulation. We all know now from reading so many articles on the microcirculation that there are perfusion derangements at the microcirculatory level that occur. So I believe that we should run higher hematocrits on pump, not lower hematocrits on pump. I think we have gone way too low in our quest to reduce transfusions, where I think there are other things we can do rather than accept this, what I consider unreasonably low threshold for transfusion, notwithstanding transfusions are not without risks. So I think you need to do anything and everything you can to reduce transfusions, but I also think we have to make sure that we are providing the patient a sufficient amount of oxygen carrying capacity and viscosity and maintenance of COP and all the other factors that play into this microcirculatory derangement, and also if enough dilution and you start to wash away your glycocalyx, and that's yet another big problem that can occur. So that's my answer to Timothy's comment. John, what's yours?
Yeah, this is a very interesting evolution. If you look back, Joe, as long as we've been around, for 40 years, maybe even longer than that, what has been one of the primary focuses of manufacturers' research and perfusion techniques? Reduce hemodilution, reduce priming volume of oxygenators, arterial line filters, ultrafiltrate, do high colloidal osmotic pressures to keep the volume intravascular, do not dilute the patient, do not give blood product. So we've done so many of these things, miniaturize our circuits, decrease venous lines from 1/2 inch to 3/8, go to vacuum, and then all of a sudden a technique comes along that kind of kicks that right in the gut, because we're going to drain 500 cc's of blood right out of the patient before we even start.
Right.
So did we afford ourselves So did we do such a good job of doing those things I just mentioned so we can afford now to take off 500, or in this case, they took off 1,200 cc's, it sounded like, right? 800 and something.
It was quite a bit.
Yeah. So, I mean, so did we do such a good job and not hemodiluting the patient because we knew all the benefits there were of going that direction, that then it afforded us the ability to then hemodilute the patient by doing taking off a unit or 2 units of blood before we even go on pump? Or are we just going backwards in all the efforts that we've accomplished in 45 years?
Yeah, so, I agree with that 100%. I've said this many times, and I continue to see it even today, that I believe our lines in many places, not everywhere, some people are really, really disciplined with this, but I have seen very long lines. And I say this is sort of my phrase. Every cc that is in a tubing line is a cc that is not in your reservoir level. And we have a minimum operating level that we have to respect for, obvious reasons. And so when you are flowing a certain amount and your level reaches a certain point, you're going to treat it. You're going to give volume. But if you had more of the blood that was in those lines still in that reservoir, it will certainly delay it and potentially not have to give it, and then you are running at a higher hematocrit or higher hemoglobin level, and when you come off pump, it's a lot easier to rinse through, if you will, chase that volume back into the patient. So Timothy says, is it feasible to do this technique prior to the operation? Well, sure. I think so. You would do the plasma sequestration prior to the surgery, right? But I think they should have given the red blood cells back before they went on pump. I would have been I would have put them in the pump. I wouldn't have any problem with that at all as part of their pump prime. I'd have no problem with that at all.
Well, I like to emphasize what Timothy's asking. Anybody who's listening to this, it is absolutely imperative that you drain this unit of blood off the patient before any incision has been made, including
Correct.
the leg incision or the chest incision. If you are draining the blood from the patient at any moment after an incision has been made in the patient, you are doing yourself a tremendous disservice.
Yeah.
Because the platelets and the coagulation stimulation and factors are being activated, and that's defeating almost entirely what you're trying to accomplish. So I'm glad Timothy's asking that. He sounds like he's curious about maybe looking into this technique, and that is a huge mistake to make. And I've seen it before where anesthesia's there hooking up the drain bag, and these guys are taking the vein and stuff. I mean, that is completely,
Well, especially sternotomy, you get just a massive surge of thrombin, right? I mean, it's just, and other inflammatory mediators, certainly. And, of course, your platelets are going to start going a little crazy. There's going to be, signals sent out. There's a lot of things that are going to happen. Yeah. So, trauma.
Chemotaxis signals sent out to activate platelets, and then that's exactly what you didn't want to have happen, which is why you don't want them to hit the circulation pump, which is why you're sequestering them. But meanwhile, now you've already started that process. And while they sit in the bag, by the way, for 4 hours or so, they're going to get plenty activated. When you give them back, they're really not helping you that much.
Yeah, I don't think so either. But, let's go back to the slides. Let's look and see what they did next. Because remember, they did this twice. They had the same patient, 2 surgeries. So let's see. Let me get to, So this is where it gets sticky for me anyway, surgery numero dos. 4 months later, as the second stage of the surgery, the connection to the elephant trunk, thoracoabdominal aortic replacement was performed. The patient's body mass index was at this time 24.7, so they lost a little bit of weight, and I wonder why. And the thoracoabdominal was computed with CT. Angiography suggested that after surgery of the aortic arch and descending aortic aneurysm, so it wasn't an elephant trunk. An aneurysm with thrombosis had formed in the thoracoabdominal aorta, as determined, okay, by this low-density linear shadow, whatever. Okay, so all of that. The lumen was divided into true and false chambers. Okay, so that's what happened. All right, so it wasn't an elephant trunk. I was wrong on that. Autologous blood separation recovery was used again for blood preservation. And this time, autologous blood was collected from the right IJ as usual. Like the first time, it's separated using ATS. Total 865 milliliters of PRP and 521 of RBCs was isolated. So, John, that's nearly 1,400 cc's, right? The device was then...
And that's not a very big patient, it doesn't sound like.
No, not at all. Are you kidding me? That's, for us, that's pediatric size here in Texas. You know that. The device was then used to achieve and concentrate the whole blood loss during the time from cutting the skin to closing the chest. It was then used to achieve... Okay, so I'm sort of confused. I don't really know what that means. Key point here is that this is about post-operative coagulation stability. So now let's look at their results of this one. After heparin neutralization with protamine, PRP, and autologous RBCs were transfused back to the patient. A total of 1,353 of concentrated RBCs, hematocrit 49%, were collected during surgery. So they had a little more bleeding this time than last time. Another 4 units of allogeneic concentrated RBCs, 4 units of platelets, and 20 of cryo, and 4,000 of crystalloid solution were administered. The total urine volume was 900, and 70 mLs of cerebrospinal fluid was drained. I'm not sure the relevance of that. I mean, that's normal, right? And the surgery lasted for 8 hours, and after removal of endobronchial blocker tube, the patient was admitted to the CVICS ICU. I think they mean CVICU. The patient received only 400 milliliters of allogeneic plasma in the post-operative phase. This is in the ICU. Cumulatively, they talk about the cerebrospinal fluid, but here I think the yellow part is what's important to us. There were no significant differences in platelet counts on the first morning, after, and 24 hours after surgery as compared with before surgery. 232, 175 versus 191, and respectively. And the MA on the TAG, again, appeared quite stable, 66, 64, and 68, pre, peri, and post. Operatively. So the key point about post-operative coagulation stability as compared with first procedure that received no transfusions, the post-op, this second procedure did require 400 of FFP, and really is that really significant to us? What do you think, John?
Oh, well, you gave platelets, you gave 20 units of cryo in the OR, then you gave a little bit more after. I don't know that you can stake a flag in the ground and say the TAG was therefore wonderful because of this technique. You gave an awful lot of coagulation factors. It's nice that they normalized the TAG, but I don't know that you can say it's because of, the ANH that they did here. I would really like to know how they managed to take 1,200 or even, close to 1,350 off of a patient that small, and how they had how their SVR must have been very high, and their volume in the reservoir was probably very low. I'm not sure how you get away with that, but I guess they have a way.
Yeah, I agree with that. So if we go ahead to the slides, these are the results of the TAG, and really I'm doing this more to show the TAG, but again, you can look through those, the RK, the angle, the MA, those are the ones that I guess really the R, the R, the angle, and the MA are the ones that are most important. And then that's the first surgery, and then you can see preoperative, and then after PRP, what they call PRP, and the second surgery, again, really they're all within normal limits. They're really no significant change. And then if we go to, let me look at this here. This is the next slide. And this, let me go here. So, and just for those who don't use TAG or don't remember TAG, I just threw this up there just to show you where the R is, which shows, the time to clot beginning, and then your angle gives you the, that gives you the speed of fibrin accumulation, right? And then the MA is what gives you the highest vertical amplitude, which is basically the strength of the clot, right? And then you have the lysis at 30 minutes and things like that. So there's various other things that it does, but that's what a basic TEG looks like. And the R wave, or the R time, and the alpha angle, and the MA are really the three things that are, I guess, are probably the most important. Unless you have a lot of hyperfibrinolysis, then you would see that, you know, in the Lie 30.
And they ended up with normal tags and everything that they did. So,
yeah,
you know, a lot of factors that could go into that. But they did give a lot of cryo. They seem to be really big on cryo.
Yes.
And, you know, what did they give? 4 platelets on that one? Or
yes, they did.
Yeah.
Yes. So they gave plenty. I mean, I think they gave plenty. I mean, that's about what we would give anyway. And you know, and it sounds to me like the surgeons are pretty doggone good at getting surgical hemostasis. And of course, you know, unless you are dealing with, you know, extremely friable tissue, which, you know, does happen, you know, and things just don't seal or tear and they're just weak. You know, if you have reasonable tissue, I think, you know, that if you have good surgical hemostasis, and it sounds like they did, surgeons were good, don't leave big holes and gaping holes for things to bleed. And then, of course, you start getting into that horrible cycle of getting a dilutional coagulopathy that you just never recover from, and all the transfusions and chasing your tail when really they need a stitch or several of them, and then you go into shock liver, and it just gets worse and worse and worse. I'm sure you've seen it. You know, we can talk about it a little bit more. But okay, so let's go to the author's conclusions on the slides, if we could, please. And then we'll go to this slide here. So perioperative anesthesia management is rather complicated, with a prolonged surgical duration and complicated procedure with rapidly changing condition of the patient. Such care covers almost every aspect of anesthesia management, protection of almost all vital organs, especially the brain, spinal cord, heart, and kidneys, but also focused on blood protection, especially protection and functional recovery of the coagulation system. And of course, we could get into the discussion about aprotein, which, you know, those are the cases that were the driest when we did those acute type 1 dissections that did really very well. But apparently aprotein was, you know, making everyone go into renal failure. That wasn't my experience, though. I have to be honest with you. Blood protection and coagulation recovery are very important to aortic surgery. Well, you can read this yourself. But let's just read the last part. In this case, the patient underwent 2 major surgical aortic surgeries within a period of 4 months. It is relatively rare for the same individual to require 2 major aortic surgeries within such a short period of time, but this case fully reflects the advantages of autologous blood separation. Blood separation was employed in both surgeries to collect a sufficient amount of PRP, as well as warming of blood and transfusion and monitoring of other body temperatures protection measures. Before the second surgery, catheterization, drainage, and manometry of the cerebrospinal fluid were performed. There was no postoperative neurologic complication. The 2 surgeries did not require infusion of too much allogeneic blood products, and some was empirical usage. So they're saying that they gave transfusions just because they're used to giving transfusions. I think that's what that says. After surgery, the patient's coagulation function had recovered well, showing that this technique can achieve relatively good therapeutic outcomes. Conducting PRP before cardiopulmonary bypass and transfusing autologous platelet-rich plasma after reversal of heparin could reduce postoperative blood loss. The requirements for blood products and transfusion during cardiovascular surgery. A higher mean platelet count in PRP may improve the final outcome. So why don't we go ahead and go to the panel discussion, and we can just discuss this very briefly, John. I think we've kind of beaten up most of it already. You know, it was a good anecdotal discussion. I can't say it was the best written paper. It may be a translation thing. I guess that is possible too, but I don't think that what they did was necessarily all that remarkable.
Well, if you or anybody out there studies a blood conservation protocol, or if you're interested in having one at your hospital, the first thing that you'll learn as you begin to read and maybe watch educational videos is that at the absolute top of the pyramid is good surgical technique. Not to place all the blame or the responsibility at the feet of the surgeon, but you can do anything you want, and if you have surgical bleed, all of your blood conservation measures are going to go right out the window.
Absolutely.
So that's one reason I said before, multidisciplinary, and it has to really be spearheaded by the top guys at your institution. I think top anesthesiologists, top cardiac surgeons, but even the post-op and pre-op, people have to have a conscious level about it. But unfortunately, if you do all those things and you just can't stop the bleeding in the OR surgically, all like you were starting to say earlier, the cascading domino effect of things that continue to get worse and worse just continue to happen, because you bleed out all your platelets, you bleed out your coagulation factors, then you're chasing them with blood donated ones, which are never as good, and you're trying to put in crystalloid to keep volume up, and you just get into a real bad downward spiral
Well,
if you can't get that surgical bleeding to stop.
Agreed. You bring up a very good point, though, about platelets. And actually, I've been talking with some folks about that, and they have a technology that can tell you whether or not your platelets are dormant or activated from the blood bank, so that when you are going to administer platelets, let's say to a patient who is going through chemotherapy, you want them to be, because you're not going to need them. You don't need them right now. You're administering platelets to patients in surgery because you need them right now. And so the ones you want for those patients who are in, just have, thrombocytopenia for some, other reason other than surgical bleeding, you want to give them this one type of platelet that has a certain dormancy associated with it. But if you have an actively bleeding patient, you want one that is more activated, at a certain level that will immediately be able to go to work and not just be lost because it has this level of dormancy that's going to take it a while in the system to actually become functional at that point in time. You need an immediate response. And that's a technology that's out there right now that I'm trying to get them over here to talk about that so that we can have them on our panel to discuss it. Because I think it's very interesting, and it's a technology I think we should be better aware of. There's so many things that we just simply don't know. We assume we get platelets from the blood bank. You assume they're going to work, or you assume, like some of us do that have been around for a long time, that they're not going to help one doggone bit. But if there's a way to actually know, then you can use the right platelets for the right types of patients. That seems to make a lot of sense to me.
Are they able to test? Are you talking about some type of device or test that tests the stored platelets in the blood bank?
Correct.
on a every so often basis, so that you know what you're getting when you ask for them?
Yes, absolutely. Yes, that is exactly what it does. This is actually done in the blood bank, not by you. It's done in the blood bank. And that way they're able to send the appropriate type of platelet to packs to the right patients. And right now, you just take a guess. So most of the time, you get the wrong ones for the wrong patient. And that's a problem, because if you're using the activated ones on the patient with the chemotherapy, you'll see this spike in their platelet count, and then it just trails right back off again. It doesn't last. And then they need another transfusion. So hopefully you'll get the right type then. And so it becomes a real problem. So Timothy asked one other question. Is it feasible? He said, is it feasible to do this technique prior to the operation? And he clarified, he was asking if you can do it like this a few days prior to surgery. And Timothy, I would say absolutely not, because then you're having to take this, you put it in the blood bank. I guess you could do that and have their storage requirements for all of these things, whether it be platelets, they have to keep moving, the plasma can be frozen, the blood needs to be treated a certain way. So you would have to do that, and I think if you did that and waited that long, you would have the same problem that you would have by just getting the blood from the blood bank to start with. I think what the China people think was most effective was that like A&H, you're doing it on that patient right now, getting it out, putting it right back into them, and there's a much lesser time of having to have them stored, because blood and blood products really don't like to be stored. So I would say no.
He's asked a good question, and it's a good point. He needs to look into all the studies that went into pre-donation, because remember, Joe, in the 90s, pre-donation was all the rage. Everybody thought pre-donation was just going to be the greatest thing ever. We go in 6 weeks before, you donate your blood, you get your blood back in surgery, and what they found out was the quality of blood that you're getting back is poor, and then secondly, the cost of the blood banking process was actually more than if you just had gotten blood that day of the surgery. And so other than the maybe lower risk risk of infection from getting your own blood back, the benefits, in fact, that's why you hardly ever see it nowadays, because it was actually a lot more expensive, a lot more difficult, time consuming, and all the blood banking negatives that go along with blood banking itself come into play the minute you have to do it. And so we're doing it in surgery. It almost costs you nothing. It costs you a blood bag with CPD in it, basically.
Right.
The Chinese spun it down, and they had some other costs there. But here, basically, we just drain it into a blood bag with CPD. The cost is almost zero, and you just give it right back a few hours later. So that's one reason why this technique felt so favorable when it came out, because it had all the benefits of pre-donation, other than the fact that there was no time for the patient to make his own blood volume back up again.
Yes.
So the hemodilutional negative was significant. But
yes, agreed. Well, let's go back to the slides, if we could, please, the split screen with us, and I'll go ahead and I think we could wrap this up. If you want to read the article, I had it referenced. I can just show it to you again. It's in, well, I have to do it this way, I guess. I have to go all the way back. I don't have any way of controlling this one over there that way. So you can see it there in Medicine reference. It was written in it was published in 2019. And if you want to read the article, there is the reference to it. And then I would like to plug Tammy's next perf web, which will be on, I don't remember the date. Can somebody tell me the date? No, that's okay. It'll be next month probably, I think. Anyways, but you can find it online, perfweb.us, and she's going to be talking about predictors of heparin resistance before cardiovascular operations in adults. That's a big problem. We've had that. And we're going to, August 10th, thank you guys. And then at the second iteration of this, of we're going to do next, which is our inaugural M&M, will be on again, learning from others' mistakes. It's going to be a different case. So each time it's going to be a new case that came out of either the legal system or the news media, wherever it may have been found. And there's also going to be another part 2 from Patrick O'Toole on should you be scavenging your anesthesia gas. We did a part 1, and now Patrick has followed up on that, and he's going to do a part 2 on that, which I think is going to be very, very, very good. We've had some really lively debates about this topic, and so I think it's going to be very interesting, and I encourage everyone to participate in it and watch us on that program. Okay, so can we take, with John, with your permission, can we take maybe a 5-minute break, just a short break, and let me grab some more tea and come back and start with our inaugural M&M. Would you mind?
that would be perfect. That'd be perfect. And just real quick, I would really highly encourage anyone watching to go back and watch Patrick's first presentation on scavenging gas. That was an incredible presentation that he did back, what was it, 6 months ago or something like that?
Yeah,
Joe?
maybe 3 or 4. Yeah, it seems like it was yesterday, John. I mean, we went, I don't know what's going on in Orlando, but we went from, and I appreciate you saying that about Patrick, because I think his presentation was really, really very, very well done. And part 2 is, I think, going to be even better. But we went here in Houston from no ECMO to I had a hospital that typically will only do 2 max at any one time with 5. and multiple hospitals this was happening in. So we have exploded in our practice, and it has been almost around the clock. But we're also seeing a lot of cases that I think had been put off during the first kind of crisis. And I think COVID, we did have a resurgence, but I think the combination of, we have a lot of other just very sick patients that have come in and have needed ECMO for different reasons unrelated to COVID. But I think it was because of COVID and them not going to seek medical care because of their fear of getting infected or having their surgery delayed or whatever the situation may have been. But we blew up, and it has been around the clock. We have been very, very, very busy.
Yeah, well, we have an 8-bed ECMO-only unit. We now have 14 ECMOs, and they're spread out among 3 units because we had to open a second COVID unit, then we had to open a third non-COVID ECMO unit.
Oh my
because
God.
of what you're saying, the regular cases are coming in, and we could have more than that. We're limited by critical care medicine, mostly. We're limited by staff.
Wow. Wow. That's just that's amazing. Yeah, it'll be very interesting to see what happens. I mean, I right now, the people that I'm talking to at the hospital are seeing some reduction in the census, and they're seeing fewer admissions into both the ICU but also the hospital. So I'm starting to see positive signs of this thing sort of tamping down a little bit. But I hope we don't have a third surge, because I can tell you right now, this second surge has been brutal for us.
Yeah, well, it's Florida, Texas, and California have now given New York a run for their money. I think we passed New York. I think I heard the other day. Even during their high time, I think.
In numbers, not nearly in death rate.
Not in deaths, yeah.
Absolutely not. And I think I've really learned that early intervention with ECMO is critical in these patients. If you wait until their lungs, they just are not, if you wait until they've been on the ventilator for 7 to 10 days, and with ever increasing requirements on the vent until you get to max, and then start seeing inability to oxygenate, and then choose to do ECMO, it's not good. You have to make the decision early if you think you're going that direction. Proning does seem to have helped. We have one patient on right now who is down to 40% on the vent, 40% on the ECMO, is getting better, has been on ECMO now for probably 20 days. But every time we take him from prone to supine, we see a real drop, and we kind of just sort of limp along with it and sort of accept it to keep his numbers, and then prone him. He seems to get a little bit better, and then we're able to make that very small incremental step down towards getting to the point of decannulation. But who's going to want to decannulate him anytime where you're not 100%, when he's not able to handle it on a supine position, because you don't want to recannulate these people at all. You don't want to do that.
It's a long, slow baby steps, but it sounds like you're doing the right thing. We are proning, which we did very little of a year or so ago. It's now almost exploded. If you do proning early, if you do ECMO early, you find out that you can make progress. If you wait too late, the permanent scarring that goes on with this disease of the lungs, it's not going to go away, and you can put them on ECMO. And sometimes we've weaned people off, and their X-ray looks almost as bad as when we put them on.
Yeah.
But somehow they're able to kind of oxygenate on their own enough to get off the ECMO. And I don't know what's going to be the eventual outcome there, but you definitely don't want to be putting them back on. And you got to wean very slow. You better do at least a 24-hour sweep trial with people like what you're talking about, because you think they're good enough to go and you can turn the vent up, and you find out maybe they're not.
Yeah, that is absolutely correct. I couldn't agree with you more on that. But I think too that my final point, and I apologize that we kind of got off topic, I know that, but it's the topic of the day, right? I think that, you have this disease which is invading this lung tissue and causing its own damage. And I think that's bad enough. And it appears, because proning has been so successful with this, that it must be causing a there's greater infiltration of the virus, if you will, in the lung tissue laterally and posteriorly. But what I also think is that when you combine that with the high pressure barotrauma, caustic nature of high inhaled oxygen content, FiO2s of 80, 90, 100%, when you combine it with that, all of that trauma is taking what was going to be lung damage and injury that may be recoverable and crossing it over to the side of unrecoverability. That's sort of where my mind is with this at this point.
Between the virus damage itself, the inflammatory response, and then the lung injury from the vent, it's
Yes.
almost like the perfect storm in a bad way.
Yes,
And
absolutely.
be very careful with all three of those, because you're going to get to a lung injury, a scarring point where you might get them off the ECMO, but they're sitting there struggling to breathe with a PO2 of 60,
Oh my God. I don't want to live like that, dude. But okay, 5-minute break, everybody. Thanks. And John, I'll be right back. 5 minutes.
Yep. Perfect.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Okay. Hey, everybody, I'm back. Welcome back. So we're going to get right to the M&M. But before I do, have you ever just felt like a dope? Probably not. I don't think so. But can I get my phone back? I need you to open a video up for me real quick. So while I was supposed to do this in the opening remarks, and I just simply forgot. And I feel horrible about it, frankly. How do I send this to you? I can text it to you, David? I need to send you a video I want you to open. I can't email it, guys. I'm on my phone. That's the only way I can do it. Okay, never mind. We'll deal with it later. Okay, so can you pull a website up for me? Yeah, which website? Okay, I want you to open up Compliance Learning Solutions with an S. Compliance Learning Solutions with an S. Learning Solutions. Just type it out. Compliance Learning Solutions. I would really just prefer just typing compliance learning solutions. There you go. Thank you. Okay, you see that in the top right there? Coronavirus training, offer free COVID-19 course for employees. Okay, so the guy that runs this, and his wife that runs this, they're good friends of mine, great people, and of course, you know, we can get all of our compliance training from the hospitals and things. Well, we actually have to, really. But for those of you out there that may be watching this program that are business owners like me, and you need to get your staff COVID-19 certified with a compliance course that is following CDC and OSHA guidelines, I would highly recommend, plus a lot of other courses, I would highly recommend that you go to this website. Now, it's very important that you type it in as Compliance Learning Solutions with an S, and not Compliance Learning Solution, because that's another company that made that website after this one as a competitor, which kind of I think was a dirty dog thing to do. But nevertheless, they have a free COVID-19 course for employees, and actually I think their stuff is pretty good. So, and it's free. So, you know, if you have office employees, or you know of somebody that has an office where they need to get people trained to help with making sure that they reduce their, mitigate at least their liability risk exposure from COVID-19 infections and lawsuits that can follow that, I highly recommend you go here. There's a video right there. It's short. We won't play it today, but I highly recommend you go check them out. Okay, let's go ahead and get to our talk. Go back with your slides, please. And we're going to do our first morbidity and mortality presentation. I was supposed to do that in the opening remarks, but learning from others' mistakes. Now, this first case that I'm going to talk about, John, this is probably everybody's greatest fear, is to have an article, a newspaper article, pop up that says one of your patients had all of their blood drained from their heart into a garbage can, killing them, according to the lawsuit. And this article was written by Aaron Alberti from Alberti from the Salt Lake Tribune. So, of course, in the article, you see this, and she looks like a lovely woman, but she is no longer with us. And so we will go ahead and preview this case. And here you see the story. The family of a Vineyard woman who died during surgical procedure last year filed a lawsuit against multiple doctors at the hospital, alleging negligence led to her death on July 10th. And this ended up national news. Several members of the patient's, Miss Donna Mae Brockbank's family, including her parents and children or those representing them, filed a lawsuit alleging that hospital 2 staff members who assisted in an open heart operation and 2 employers, Brockbank died during the surgery at the age of 62. She looked like a pretty vibrant 62. They named the doctors as well as the hospital, as well as the perfusion company that are listed as the defendants in this lawsuit. The document also shows plaintiffs are seeking an unspecified amount in special damages and general damages to be determined in a trial, punitive and exemplary damages, pre or post-judgment interest, as well as attorney fees, and they're represented by 2 law firms. In the lawsuit, the family alleges that the patient bled to death and that the physician that did the case failed to close or clamp a tube or line carrying blood being pumped from her right heart after the surgery was over. After they left the room, the family alleges the person who operated the heart-lung machine, that would be us, the perfusionist, during the surgery, also known as a perfusionist, took a disposable venous arterial reservoir, which is where the blood is stored during surgery, and placed it in a medical waste garbage can after the surgery was done, and the patient's heart began beating again. Shortly after The patient's vitals began to collapse, and she was in severe distress because all of her blood had drained into the reservoir that was sitting in the garbage can, the suit alleges. None of the medical professionals in the operating room apparently noticed that there was now a full venous reservoir, a full venous blood receptacle in the garbage can, and that the cannula line was still open. The surgical team pumped several units of blood into the patient, but the fresh blood was not staying in her circulatory system. It was instead traveling through this open cannula into the reservoir, sitting in the garbage can on the floor. She was later pronounced. The news media outlet reached out to St. Mark's for comment and a statement. The CEO said, "Our hearts go out to the family, and we want to again express our condolences for their loss. We seek to learn from every patient's situation in order to continuously improve the quality and safety of the care we provide throughout the hospital." So this is sort of here kind of what happened. She had an ASD closure device that is made of nickel, and she supposedly had a nickel allergy and was having headaches and things like that, I guess, that are associated with this, a nickel allergy. In the lawsuit, they claim that, or allege, that they cannulated, it sounds to me like what they did was they cannulated femoral venous, long VFem, and an opti in the right IJ and wired them together back into the reservoir, because they did this as a minimally invasive procedure. There's several, of course, allegations being made against everybody, and it sounds like it was a horrible day. And my questions are, what the heck happened here? Some key points to this discussion is team cohesiveness, everyone having the same knowledge of what you're doing during this case, the skill level of everyone on the team doing this case, because by no means, and this is something that I think is very important. John, we'd elaborate on this later, but I don't think this is a chip shot case. Sounds like a chip shot case. For the surgeon, I think it's a chip shot case. It's not a chip shot case for a perfusionist. What was the backup support like? Was there any? How can this happen to begin with? It's happened before. This isn't the first time. How is this not a sentinel event that has been addressed? We have timeouts for a reason. How does this even happen? And could it have been avoided? Well, I think so. We could discuss that. And then what should happen? What should happen to the participants of this procedure? You know the fingers are pointing. You know that's happening. So I think that's my last slide, yeah. So, John?
Yeah, I have a lot to say about this, Joe, because I've had almost every aspect of what happened in this case. I have either witnessed or it has happened where I worked. And funny thing is, something almost identical to this happened with myself, was with two other very, very experienced fusionists in my very, very first job. And it's funny that this happened in 2018. You're saying it happened in 2018, because when this happened at the institution I was at was in 1988. So you're talking about 40 years. This identical thing happened where we emptied a patient's blood volume into the red bag while the lines were still up on the patient. And it sounds like that's exactly what happened here. So, and then but back in 1988, of course, we didn't cannulate people's right IJ and started doing these fancy cannulations with mini procedures. And I also had a mini procedure where the right IJ was cannulated and nothing unthwarted happened. However, it was complicated for several other reasons, because the IJ cannula is under the drape. No one sees it except the anesthesiologist. And in the particular cases that I did, a couple cases like that I did, I had to rely on the anesthesiologist. I had to hand him a pump clamp, and he was doing something over there with that cannula when it became where it wouldn't drain properly. And this made, for a very nerve-wracking situation. He asked me for a pump clamp. He wanted to do something, I forget what it was now, it was more than 5 years ago, doing something there with the thing, and then, was it clamped, was it not clamped? And it sounds to me like, I'll tell you what happened on my case. I was a 1 year out, maybe less than 1 year out perfusionist, and the two other perfusionists I worked with were the original perfusionists maybe ever from the 1950s. OJT, respiratory therapist, had 30 years experience by the time I'd even gotten there, and I had done the case. And back then, we had a call schedule whereby at 3 o'clock in the afternoon, the first call came and got you out of your case, regardless of where you were. So on my case that morning, it was a reoperation. And so if you recall, Joe, a lot of times we would femorally cannulate the patient, go on femorally, then go ahead and open the chest, and go ahead.
We still do that. We still do that in places.
Yeah. So we'd go on to collapse the heart, and then when we open the chest, they actually, in this case, went ahead and put an aortic root cannula in, and we moved the aortic line, and we put a venous line in, because back then, femoral venous cannulas were not very, they were very thick. They didn't drain very well. So we left the femoral venous cannula in, but we also added our right atrial cannula, and we added our aortic root cannula, and basically towels and instruments and things eventually covered up the femoral venous drainage line that we had also working this entire case. So the case went very well. It was a reoperative CABG, and it went very well. And lo and behold, comes 3 o'clock, we were off pump. The surgeon was closing and everything, and the perfusionist comes in to relieve me, and basically I'm explaining that, we're off, and we're basically sending blood over to the cell saver, and we're basically mopping up at this point, and he takes over, and I walk over to the locker room, which is still inside of the OR back then, and I was just barely changing my clothes when I heard code blue to the OR number 2, I think it was, where we were working. It was the only case going on. And I'm thinking, that case was perfect. Why is this patient coding? And I thought, maybe I should go back in there. I said, well, I got 35-year experience perfusionist here. What am I going to do? And I heard it call code blue again. So I put my scrubs back on for some reason and went back into the room, and I walked in. I said to the perfusionist, what's going on? And the pressure was literally 10, and it was a full-blown code. Everybody was doing what they could do. And he says, I don't know. I think somehow they've exsanguinated this patient. Well, he had taken the entire pump and put it into a double red bag. So the lines were at the table, but you couldn't see anything. And immediately I thought to myself, I bet the femoral cannula, venous cannula was still in. And I look in the red bag, and lo and behold, the blood reservoir was full. I quick grabbed it, put it back on the pump. And back those days, we had an arterial venous shunt where we could push blood back up the venous line, because we used to give blood up the venous line those days. And I just completely refilled the patient with his blood. Amazingly, the blood had not clotted in the system. Don't ask me how.
That
and
is
the
amazing.
blood pressure came skyrocketing back up. And believe it or not, the patient did perfectly well. And there was no worse for wear, believe it or not, because I followed the patient in the ICU the following several days, so they finally went up to the floor. But that was one scary incident that happened. So, and when you combine with what happened here, sounds to me, when I did a mini procedure at this case back in 2015, they would cannulate one right IJ cannula, but they also cannulated the femoral, because you couldn't get enough drainage with just that. And that right IJ cannula is under the drape. The only person who can see it is the anesthesiologist. And you mentioned that you thought that they wired the lines together. I'm not so sure they did that, because what we did is we had a half-inch venous drainage line coming down from our femoral, but this was a separate 3/8 line from the right IJ that we plugged into the top of the reservoir into a 3/8 port right there. So we actually had 2 venous drainage lines coming down. And that was kind of nice, because in a way you had to look at that and you constantly remembered that I've got a separate venous drainage line going over to the right IJ. And I remember at some point the anesthesiologist, I think the cannula they put in had a lure on the top, like a lure, lure cap on the top. And they wanted to do something with that. And he asked me for a clamp because he wanted to put a stopcock on there or something. Meanwhile, we're using this cannula as a drainage. And so here it is, I'm looking back at the pump and straddling over to the anesthesiologist, what are you doing with that clamp? You know what I mean? So it was very unnerving, just because, here's somebody who never even deals with a tubing clamp, who are asking for a tubing clamp to do something with a cannula that I can't even see. The surgeon's not even seeing it. It's under the drape. So somewhere along the line, this perfusionist and a surgeon forgot about it, and then came time to throw the pump into the red bag, put the pump in the red bag. Well, what is the last thing you do after you put the pump in the red bag? You take your clamps off, right? Because you don't want to throw them clamps away. And so what, if you read the article, it sounds like, you know, that it didn't happen right away. It's like the perfusionist put it in the container, but it took some time before they noticed that the patient coded. And I think there was a minute or two while they were fumbling around and getting the bags all situated. And then finally popped the clamps off, and bingo, there went the drain for the IJ. And it wouldn't have taken very long, I can tell you that.
Yes, well, absolutely. And they, you know, they did, the story's a little deeper, but they did give a lot of products. And according to the court filings, they did wire the line together. So they brought it from the neck down, and then used and they used VAVD. So they had a 3/8 inch venous line as opposed to a 1/2 inch. But you could do it with a 1/2 inch too. You just have to have a reducer, right? 1/2, 3/8, 3/8, or whatever you're going to do. So, you know, or step it up and have it 1/2 inch. You can do anything, right? I mean, really, at the end of the day. But well,
let me stop you right there, because what probably happened is, from the perfusionist standpoint, he's looking at the drape. He sees that the femoral venous cannula is out, right?
Well, the surgeon,
he sees that it's out, he or she sees it's out. That gave the impression that all the lines are clear. So when he took the master clamp off back behind the Y, you know, it drained the right IJ.
Mm-hmm. Exactly. Well, in this case, actually, the surgeon had left the room.
Mm-hmm.
The surgeon left the room. They were starting to take the drapes down.
Mm-hmm.
Because when you think about it, you have to really wrap your head around this issue. They're taking the drapes down. They are, in fact, the scrubs had thrown, or the scrub had thrown the lines from the leg onto the floor. It was they were on the floor. And so the perfusionist is like, you know, okay, it's time to take the pump down, right? And oh my God, you know, I mean, it makes sense, because when the patient became unstable, nobody even thought about it. They're in there opening up the incision to look to see if they're bleeding. I mean, the surgeon themselves who put the line in, everybody in the room, anesthesia who is right there with this thing sticking out of their neck. It's not just a small little catheter. It's not like an IV. It's not a swan. It's a 22 French cannula. It things are big, you know. It's and tubing going around it. So I think it's just remarkable that this happened. It's very hard for me to believe that this was even able to happen, and I really worry. I think my issue is, you know, and this is going to make me do this, is to go back and look at our checklist. We have a pre-pump checklist. I think we need to have a checklist for before you take all those clamps off. You best make sure. I mean, why is this not even, I mean, this is Karma down in Australia tells me on our page. He says, I heard a story similar to this, where a perfusionist went to pack up the pump. It was in a yellow clinical bag next to the table. I guess they use yellow for dirty there. They took off the venous clamp, and the patient exsanguinated through it, through the neck line. So it's happened in Australia. He says that, let's see, getting compliments about the webcast, which is nice. I appreciate that. Thank you so very much. But it says their caseload has dropped quite a bit when they moved to stage 3 restrictions on referrals now with the COVID crisis, which I appreciate. But I mean, but getting back kind of full circle, why is this not something that is talked about more? You know, all of these protections for the patients, nobody ever thinks, you know, it's like the pump is an enigma. Perfusionists and the pump we're there, but it's kind of like we've never, it's like we're not a mirage. I mean, we really have a tremendous impact on these patients, and it makes no sense to me that this could happen. I know of another case in another city, I won't say where it was, where they did a pediatric case, and this is where communication really matters, and I think I want to go back to that because I think it's very important to talk about these other items. We have a little bit of time left, but they tore the pump down, and they had the clamp on, but they opened the arterial filter stopcock, and the vent was still in the aorta. And that baby, it was a pediatric case, exsanguinated and died. I mean, the baby died. So this is not
It wouldn't
something.
wouldn't take much volume loss to have a.
And
Yeah.
right. And so here you are, happened to you. Here's somebody in Australia. They know about this happening there. I know about it happening in an institution where I used to work, so I have firsthand knowledge of it. And then you have these reports, this report in the news about this case. So really, let's look at this from this perspective if we can. How much of this do you think can be associated to team cohesiveness? Is everybody really working together? Can this happen if you have a strong, cohesive team that works really well together? That's my first question. My second question is, did everybody in this case really have an understanding of what it was they were doing? The third is, and I said at the beginning, what is the skill level? This by no means, in my view, any minimally invasive case where you're doing minimally invasive cardiac surgery, perfusion is the most complicated versus the standard cases that we always do. So what was the skill level? And those are really my three questions. So what do you think? Let's start with team cohesiveness.
Well, let me just back up 1 second and make a couple statements, and I wrote your three questions down here, so I think I can remember what you said there. So, Joe, it occurs to me that one reason, what you were saying a minute ago about how does this happen? How can no one not notice? Well, Joe, when we always cannulated the chest, and was always cannulated the chest, you could see that both lines were out. Now we're cannulating all these exotic ways, and so, you begin to, you get into a habit of saying, oh, the lines are out. Well, wait a second, we have lines in places that, we've never put lines before. This, I would envision in this case, number one, that if you've never seen it, I'm sure you have it, for people listening, this is a cannula that has become invisible because it's under the drape, number one. Number two, I wouldn't doubt if the anesthesiologist, and trying to be diligent, took a green towel or two, and wrapped it around the cannula, kind of support it, maybe put it in between the neck, and kind of, maybe he or she kind of hit it from him or herself a little bit. Maybe they ran the line along, just under the patient's arm, maybe along the railing of the bed, so it came straight back to the perfusionist and wasn't draping where the PA had to stand or whatever, because, it's in a terrible spot, believe it or not. So maybe some of these things happen, but over time, people sort of began to forget about it. But beginning to your question now, the cohesiveness of it, I wonder how many times this OR team did this particular cannulation. In the center that I worked, we did it twice in the entire year. So the anesthesiologist was fumbling, like I said, wanted a clamp, wanted to mess with it. I was trying to figure out a nice way to not have it be stepped on, but yet not have it kink, where I could see it. If I could get air in it, could I get the air out of it? All these things. So I wonder how many times this OR team did this particular cannulation. I bet it was pretty small, is my guess. And
it's possible. It's possible, or you just, I talk about team cohesiveness a lot because there are some places you go, and of course I'm a big believer in this, that when you have a group of people who get along and like each other and work well together and are professional and respect each other and are able to speak up and talk and there's good communication, I think these things happen a lot less. And my gut instincts tells me that this was probably not the case. And again, I could be wrong, but that's just sort of my gut instinct is telling me that. Our down under colleague says that when they do this cannulation, that they double clamp the venous neckline so it triggers them to double check so that this doesn't happen. And he guesses, of course, and I agree, that it's probably, and it's what you just said, it's not really a common way to cannulate, and people aren't used to it. And I think that's another truism about this. But I still, I'm just baffled that nobody thought of it. Here's the patient is exsanguinated, and they're pumping all this volume in. Well, if they had remembered nobody remembered it was there because they would have used that line. And
you bring up a good point. I mean, how much time? The instant that I walked into the room and my perfusionist said to me, "I think they've exsanguinated this patient," instantly I thought of there's a cannula still in.
Mm-hmm.
I wonder how much time these people. I mean, it takes time to get blood up from the blood bank. You have a couple of units or so in the room, but you don't have.
Could be in a cooler in the room. We used to get, it could be in the cooler in the room. We used to get 4 units up all the time in a cooler.
Yeah, okay, but it sounded like they had given a bunch of other stuff. So, I mean, the time that it would take to hang it, to give it, and then they keep noticing that and somebody came back in and reopened the chest, right?
Yes.
The surgeon left.
Opened the incision, the right anterior thoracotomy, I'm assuming, and then also did a sternotomy and was like, the heart is empty. There's no blood in it. And still nobody thought. But the question now I have, and let's get serious about this if I can, is it, and this is a tough one, but whose fault is this? I know it's everyone's fault, but whose fault is this? If you're tearing the pump down.
Question about cohesiveness and so on, I would be interested to know if between the anesthesiologist, the perfusionist, and the surgeon, if any of those were outside travelers. You know what I mean?
Yeah.
I would be interested to know that. I'd be interested to know how many times per year that the people in that room, not the whole institution, but the surgeon, anesthesiologist, and perfusionist, cannulate the neck on any given procedure. Now, your emailer there that you're reading from, they have a double clamp system. Why? Because they do this more often and have learned a technique to prevent a problem. This is not somebody who does it the very first time and they've come up with a double clamp technique. They've done that because they've learned some things, probably.
Well, I'm going to ask Karma. Karma, do you do that because of the story you said you had heard about, or did you just somebody think to themselves, this could happen? And while you're thinking about that, to see if I get a response from you on that, the thing is, John, if you tear the pump down, you throw it in the waste bag, and you may truly believe, well, they're done, they just threw that line off. I mean, you should know where the patient was cannulated. You should know that. Should you not be paying attention to decannulation as well as you are to cannulation? How deeply involved should you be in the case? What makes a good perfusionist? Of course, what was this person's experience level? Again, I have to ask that question, because for that to happen to me would be, I think you would have to view it very differently than to a new grad who had limited experience, and then you put them in on this case. And like I said, this is not a chip shot type of case. This is a very odd case. These are difficult cases to do for perfusion, not the surgeon, not anesthesia, not the nurses, it's the scrubs. It's the person with the most challenging situation is the perfusionist. But should you not know, hey, you never took the neckline out, is somebody going to do that?
The majority of the fault is going to lie with the perfusionist, and I'll tell you why. Because you said they wired that line together. Now, how many times in your career, I bet it's very, very few, that you have a Y dead center of your venous line, not too far from your oxygenator? I can't recall too many times, even the times that we cannulated the neck, we had a separate 3/8 line from the neck and a separate venous line. And having 2 venous lines was very odd, because imagine, how are you coming off? You're clamping each one, how much, it was very odd. So this was an odd case. So
I would just clamp the IJ and forget about it. I'd clamp it and come off with the regular cannula. I wouldn't even think twice.
How did they take a clamp off the line and not be very close and see that Y and think to themselves,
That
Where does
doesn't.
this
Wait
other
a minute.
branch go?
Wait a minute. What if the Y was on the field? I told you the leg lines were the groin lines were on the floor. Okay, so if the groin lines were on the floor, the only person that would have taken that clamp off if the Y was at the field would have been the field, while they were getting ready to take the drapes off to take the patient to the ICU.
Well, no, I don't think the clamp. I don't see the field having a clamp on that line because it would have been open the entire pump run, and the perfusionist would have come off.
It wouldn't have been. It's
main
connected,
line.
John. You got the right IJ lines in here like this. Your femoral venous is like this. You put it in. You take a 3/8 tubing. You bring it like this. You cut into your line with a Y connector, and now you have one going this way, one going that way. And when they came off pump and they were clamped, they could have clamped it anywhere on there, beneath let's say distal to the patient on the line, come off pump and clamp the femoral venous line, the femoral aspect of it, and then when they're getting ready to clean up, they just pop those clamps off, throw it on the ground, it goes into the trash bucket. Nobody's ever put a line on the one from the neck at all. So the perfusionist just took their line off, put it in the bucket, and took the line off.
So you think it was wide off, very high up near the femoral cannula? That's where the
why
Y
not?
was.
Sure, I've done that before.
Yeah, but that's strange because see, your cannula is not sterile. It's under the drape, and you would have had to take a 3/8 line to go that was unsterile and bring it up onto the sterile field. I mean, how did that happen? How did that happen in the draping process?
I don't know, but I mean, I have done it. I have done it myself.
Okay.
So I mean, it's not like, and I've also done it the way you said with two venous lines. I've done it both ways, and I think it's just very hard for me because I don't know what the skill level of the perfusionist was. I don't know how long they had been a perfusionist. I don't know how many times they had done minimally invasive cases. There's a lot of questions that I have, but I can tell you that this had to have been devastating for this person, number one. Devastating for the family, obviously, of the patient and the patient themselves that lost their life. But I also just think that cardiac surgery is a team sport. We all gotta be, you win as a team, you lose as a team. But I just, from reading the documents that I read, a lot of this.
Oh, well, that's what happens, yeah, unfortunately.
No,
but I'm not, don't get me wrong, I'm not vindicating the surgeon or the anesthesiologist. The surgeon put the line in, should have remembered that the line was in. Anesthesiologist is staring at it the entire case, should certainly have remembered there's a huge line in my patient's right IJ, which, by the way, most of them are upset about that because that's right where their swan would have went, so they were probably grumbling about that the entire case. So I don't know how they forgot about it. So there's plenty of blame to go around about, this patient's getting ready to be undraped, and we've got this gigantic line still in the right IJ.
I think so too. So our friend down south says that his reason they do it is that they noticed a potential for it to happen for all of the above reasons, and the neckline is hiding under the drapes, as you said, and we rarely cannulate the neck. He went on to say when we do it, we use a pack of extra tubing, which, pretty common, which is capped at each end, and you can stay sterile as you pass it to the anesthesiologist is how they do it. So they do it the way you had described it having been done, because it actually does not mean that it has to be under the drapes. It doesn't have to be. You can put that in. You can actually take that tubing, put it in, and you could flush that, and you could actually flush that tubing, that piece of tubing, if you wanted to, and clamp it and make the connection with a little dribble and so forth, and then prep and prep that as well, and actually have it fairly well, exposed. You could have it so you could see it.
So what you just described is exactly one of my points that I didn't make very well, and that is this is involved. To get this cannula in the neck, it's involved. To connect it to the circuit in any type of sterile or under the drape way or whatever is involved, and to maintain it working throughout the case is involved. So that is what's most perplexing, that all three of these primary persons involved, perfusionist, anesthesia, surgeon, forgot about this when it's such an involved thing. You know what I mean? It's not just something you just, turn the stop clock and you forget. It's a big involved process that it's kind of hard to forget about.
I totally agree. I totally agree with you 100%. My takeaway message from this is that I think perfusionists, if you're listening out there, whomever may watch this in the future, it doesn't matter, you really have to stay engaged with the procedure from start to finish. One of the things that is the hallmark of perfusion throughout the very distinguished history of our profession is that we see everything. We pay attention to everything. Sometimes we make people aggravated because you're watching the pressure. I think they might be in VTAC. Did you remember to take that cannula out? Doc, I don't think we've given the heparin yet. The list goes on and on and on and on and on. But that doesn't happen overnight. That requires experience. And so when you take these relatively, and they're great people, they were great students, they did fantastic in school, but we turned them out, and now they're even turning them out faster because of COVID, okay, which is, I think, just really silly to do that. They just don't have the experience, and we're not pairing them up, we're just sending them out on their own into some, place in the middle of nowhere and saying, good luck, go ahead, have fun, you're going to Utah, and here, let's do this minimally invasive case today, and we're going to do this exotic cannulation that you may or may not have ever seen before. And you know what? They might not even like you, so they don't treat you too nicely, and they aren't communicating with each other. And it's one of those environments that's, that kind of what's that environment? I'm trying to say the word where you're, hostile. That's it. And then the next thing you know, this happens. But
I absolutely agree with you. My suspicion is that this was a little bit somewhat
toxic. That's it.
I think what was it? Mark Cruz back in the days when he was doing all his studies, and others many after and before him, found that medical accidents are almost always a series of three things that happened. It's usually not just one mistake, right? So my suspicion is one of these first step was they very rarely did this procedure, or maybe there were some new people working in the room that were from the outside traveling, or just new working together, period. Number one, something like that. Number two, I wouldn't doubt if there was a toxic or hostile environment somewhere along the line there where people are really, they just want to bury their head and try to get through the case, and thank God this case is over and let me get rid of this and get out of here. And then thirdly, it was just a lack of paying attention on several people's part.
Yeah.
The case, I wouldn't doubt, this was a simple closure of an ASD, right? They
removed the removal of an ASD device,
and a PFO and closed it.
That's it. Primary closure.
How long did you have been on bypass? 12 minutes or something like that?
Maybe 20, let's say 20.
Yeah, it probably took longer to put this neck cannula in than it did to be on the pump, yet people have already forgotten about this huge cannula in his neck. So there's something that people weren't enjoying working with each other in this particular team. I don't think.
I agree with you.
Of a very unfriendly environment.
I agree with you, and I think that the potentially the lack of skill of the perfusionist in this case proved to be the undoing, and that is unfortunate, because again, I think that when you don't have the experience to do certain types of cases, or you think you do and you shouldn't, but you think you do, that's even worse. They should have been supported with somebody else working with them if they were in fact inexperienced. That I think may have made a difference. But my central message is, we're perfusionists. We are known for seeing everything that's happening, sticking our nose in places where we're not wanted or people don't think we belong. but we have real thick skin, and we do it anyway because we are the ultimate inpatient advocates, and this just should not happen. I'm going to develop, I think, for my team out here, a post-pump, pre-teardown checklist that is going to ask a couple of very fundamental questions that should be done, or put a sign on the pump, whatever I need to do, because I've heard of this story happening too many times to recognize it can happen to us, and I don't want it to. And it shouldn't be something that could ever happen. So those are my thoughts.
So there's some, Joe, we always do these things, and we like to send the audience with something that I can do tomorrow that makes me a better perfusionist. And what you just said, by the way, is a perfect one for people to do. Before I take these clamps off, have I checked A, B, C, and D?
Yes.
I'll tell you another one, by the way. A lot of people forget to turn their anesthesia gas off, and it runs for 20, 30 minutes, and then they have to crash back on pump, and lo and behold, there's a ton of vasodilatation that occurs. That's a different one. But at least this one, is not catastrophic. But I'll tell you what perfusionists need to do every minute of every day. This is what they need to be thinking. And I hope they teach this in schools. And I'm not so sure they do. And that is what just happened, what should happen next, and what could happen.
Mm-hmm.
So what did happen, what should happen, and what could happen. Mm-hmm. And if people think about what could go wrong or what could happen when I go ready to take this clamp off or move this or move that, they'll think ahead. You cannot be thinking currently in perfusion. You have to be thinking one step ahead. And that one step ahead says what should happen and what could happen.
Yes.
Right?
Great point, I think, to end the program on. John, I want to thank you again. I've enjoyed the inaugural M&M conference. I mean, it's sort of interesting. I think next week is going to be another case that's going to make people go, oh my God, can that really happen? But I think this is really where you learn. This is what you learn from others' mistakes, which is sad, but that's true. We don't want to make them ourselves, so let's learn from others and then become better at what we do. So I hope Tammy was pleased with my my hosting of the Tammy Sparacino Journal Club. We're going to revisit that again also on the 10th, I believe, is what they told me, and another one of these as well. Hopefully you'll be able to join us then as also, John. You know, you've become a staple to the program, and I can't thank you enough. I appreciate you more than you'll ever know. I know you've been done at the hospital for over an hour now and have stayed in order to be on this program, and I know that's an enormous sacrifice, and I just appreciate you, and want to let everybody else know that they should appreciate you too, because you're very wise, and you've seen a lot, been around a lot, done a lot, and have some very, very, very poignant messages. So thank you.
You're welcome. I appreciate it. I enjoy doing it, as you know.
Thank you, sir. Okay, we'll go ahead and I think close for the day, and we will be happy. Is that what's up? Everything okay? Oh, that's you. That's you. Oh, somebody's calling you, John, overhead. Okay, I couldn't figure out what it was. I want to see everybody on the 10th. Thank you all again for tuning in. I appreciate you. Let's get through this COVID, this latest COVID mania, and hopefully it shall end. We'll get a vaccine. We'll get some good treatment options, and we'll be able to come out the backside of this. I see some hope on the horizon, so I think we just need to stay positive and do what we can. So best of luck to everybody. Stay safe, and we'll see you next time. Thank you.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.